anesthesia. The first rule of anesthesia at Humane Alliance is all tractable patients are examined by a doctor prior to the administration of any drugs. This rule is to ensure that they are acceptable surgical patients. It also allows the doctor to make any adjustments to the anesthetic protocol for that individual patient as necessary. The first drugs we administer to dogs are referred to as pre-meds or pre-anesthetic medications because we are using them prior to general anesthesia. These drugs decrease anxiety, provide preemptive analgesia or pain control, and reduce the dosage of anesthetics needed for surgery. The pre-meds we use are morphine and acepromazine. Morphine is an opioid which provides pain control and sedation. It also causes dogs to vomit. Acepromazine is a tranquilizer that provides no pain control. In general, they are dosed by the patient's weight and are administered subcutaneously. After the administration of the pre-med, the patient is placed in a cage and checked frequently for the onset of sedation and emesis, or vomiting. This usually begins to occur within about 5 to 10 minutes, and sedation may increase over the next 30 minutes. Induction of anesthesia should not occur earlier than this 30-minute window. Clean the animal promptly if vomiting occurs and address hypothermia issues. Excessive sedation, difficulty breathing, or any other abnormal responses require immediate notification of a doctor. A dog that cannot lift its head and look at you would be an example of a patient experiencing sedation out of our normal range. This pre-med gives a time range of about 4 hours maximum for sedation and analgesia. At this point, technicians should prepare baggies for each patient containing the induction agent, injectable pain medication, and any vaccinations or additional service items. An induction agent should cause the patient to briefly lose consciousness in order for a technician to place an endotracheal tube in the trachea. We use ketamine combined with Valium at the Humane Alliance. For our injectable pain medication, we use meloxicam, which is a non-steroidal anti-inflammatory drug for any patients over 4 months of age. For patients younger than 4 months, we use buprenorphine, an opioid. Pediatrics, geriatrics, and those patients more susceptible to hypothermia or other complications should be brought out first in the surgical order. Patients should be lifted onto a prep table onto a clean blanket. The patient's drug baggie should be matched with the patient's name tag at this time. The technician may then obtain an endotracheal tube of the appropriate size and lubricate it with sterile lubricant. We loop string around the tube to tie the tube in place after intubation. The technician obtains the induction agent, ketamine and Valium, with a new 25-gauge needle and also an alcohol swab. The assistant positions the dog sternally and holds off the cephalic vein in either front leg. The technician then injects the induction agent intravenously. Over the next 1 to 2 minutes, the dog is allowed to deeply relax until the jaw can be opened and the tongue can be pulled out and downward. The technician is then able to insert the endotracheal tube into the trachea and anchor it by tying the string around the maxilla or behind the ears. Intubation is necessary to protect the airway and to maintain the dog under anesthesia using anesthetic gas. If the dog is too awake to allow intubation, the technician alerts the doctor. Try to avoid mask inductions as much as possible as they increase environmental contamination. The doctor may opt to have the technician administer more induction agent, usually 1/4 to 1/2 the original dose, or place a mask on the patient's face and administer gas anesthesia. The technician will attempt intubation again once the patient is further relaxed. After intubation, lubricate the dog's eyes. This protects the corneas from drying out as anesthetic drugs decrease tear production. We use corn oil as a lubricant. Place the dog in a V tray and roll the dog onto his or her back. The oxygen flow is turned on to 1 liter per minute and the F circuit is attached to the endotracheal tube. At this time, we select the isoflurane or gas anesthesia concentration after the patient has been assessed. Parameters for a quick initial evaluation include movement of the patient, chewing, and breathing. The technician may choose to place the patient on a higher or lower isoflurane concentration depending on how light or awake the animal may be. The technician then inflates the cuff of the endotracheal tube. The cuff should form a gentle seal to prevent escape of anesthetic gas, but not be overly tight, which can damage the trachea. Place the pulse oximeter probe on the tongue and obtain a reading. Check your patient's reflexes at this time. Is jaw tone beginning to relax? Does she withdraw her foot when the toe is pinched? Does she blink when the lower eyelid is touched? The goal of anesthesia is to achieve and maintain a surgical plane of anesthesia while using the lowest concentration of isoflurane possible. With this goal in mind, frequently assess your patient's reflexes, as well as heart rate, respiratory rate, gum color, and capillary refill time, all through prep, surgery, and recovery. We strive to maintain our patients on an isoflurane concentration of 2% or less. The patient should maintain minimal jaw tone and palpebral reflex while losing the pedal or toe pinching reflex. If your dog is too light, discuss with your doctor how they would prefer to deepen anesthesia. Some options include 1. Increasing the oxygen flow rate to 2 liters per minute while keeping the isoflurane at the same level. 2. Increasing the isoflurane concentration by 1 to 2% while keeping the oxygen flow rate at the same level. And 3. Giving breaths to your patient. During this time period, do not leave your patient as she needs close monitoring and supervision. If your dog is too deep, decrease or shut off the isoflurane depending upon her depth. If necessary to lighten her plane of anesthesia quickly, shut off the isoflurane and flush the system. This is accomplished by unhooking the F circuit and covering the whole of the F circuit with the palm of your hand, then squeezing the reservoir bag until empty. Depress the flush valve to fill the system with oxygen and squeeze the bag again. Then hook the patient back to the F circuit with the oxygen flow at 1 liter per minute. You may additionally give more breaths at this time. When the doctor is nearing the end of surgery, obtain the OK to shut off isoflurane and leave the dog on oxygen. Some doctors may also prefer you flush the system at this time as previously described. Ideally, patients should have 5 minutes on oxygen after the cessation of isoflurane. Before removing the patient from the surgery table, always deflate the cuff of the endotracheal tube. Leave the tube anchor in place until the patient is positioned for recovery, then untie the anchor or string. Pull the tongue out of the side of the mouth facing up to be easily visible. This helps to visualize color and movements indicating swallowing. The endotracheal tube remains in place until the animal has made several swallowing attempts. This ensures the dog can maintain a patent airway and reduces the risk of aspiration. When you extubate the dog after these swallowing attempts, gently pull the tube following the curvature of the trachea and tube. For continued information on recovery, see our recovery module. Anesthesia requires much practice, observation, and experience. Most importantly, always be vigilant and aware of both your patient and those patients around you, and always speak up quickly if you suspect something is wrong.